Contrast-induced nephropathy, using baseline kidney function to determine prognosis. Background, epidemiology, and etiology. Contrast media started being used for diagnostic purposes in the late 1920s by Dr. Moses Swick while performing a urogram in order to treat syphilis. Since then, contrast media is used to enhance vasculature and other body tissue during radiographic imaging. The definition of contrast-induced nephropathy is an increase of serum creatinine 24 to 48 hours post-administering contrast media. This is an increase of 0.5 milligrams per deciliter of serum creatinine or 25% increase in creatinine level from baseline. Initially, the belief was iodine contrast was a primary culprit in causing kidney injury in patients after the body breaks it down and excretes it. However, after years of research, it has been determined certain comorbid conditions and baseline kidney functions significantly increase the likelihood of kidney injury with the interaction of contrast media. These comorbidities include chronic inflammation, diabetes, chronic renal insufficiency, congestive heart failure, multiple myeloma, and inflammatory prothrombotic states. Also, a baseline estimated glomerular filtration rate of less than or equal to 36.8 has been proven to significantly increase the incidence of contrast-induced nephropathy. In the picture, you can see a coronary angiogram, and these are very commonly used to diagnose patients with atherosclerotic buildup. And since they're used so often, it's very common for these types of patients with certain comorbidities to develop contrast-induced nephropathy. Pathophysiology. The exact mechanism is unknown, however, there are several theories, some more accepted than others. One theory includes renal vasoconstriction of various causes and direct cytotoxic effects of the contrast agent itself. Renal blood flow may be decreased up to 30 to 45% less than baseline flow for several hours after contrast media. This is secondary to vasoconstriction resulting in hypoxia, which is mediated by nitric oxide and prostaglandins. Also stated in certain research studies is there's an increase in blood viscosity further exacerbating the hypoxic environment. And here in the picture shown is the anatomy of nephron and the blood flow throughout it. Signs, symptoms, and clinical presentation. Patients who are diagnosed with contrast-induced nephropathy are usually asymptomatic and only go through a transient decline in renal function that can only be determined through lab analysis. If they do have symptoms, it's usually that of fatigue, poor appetite, swelling, dry, itchy skin, those similar to an acute kidney injury. For labs and imaging, serum creatinine is used as the main indicator of CIN. Urinalysis is ordered to exclude other possible etiologies. A urinary sediment would demonstrate a muddy brown granular and epithelial cell cast, along with free renal tubular epithelial cells. A fractional excretion of sodium. It's typically less than 1% in CIN. Greater than 2% indicates other etiology. Ultrasound is another modality of diagnosis which would demonstrate similar results to acute renal failure if severe enough. However, ultrasound isn't very often used. Treatment. Of course, the best treatment would be to avoid any nephrotoxic agents at all. However, sometimes these tests using contrast media are necessary in diagnosing a patient. If they are diagnosed with contrast-induced nephropathy, the treatment is similar to that of an acute renal failure, which is just supportive care, maintain hydration, and limit further renal injury. There's really no specific antidote available. Hydration, typically 0.9% saline IV, is used along with oral fluid intake and avoiding nephrotoxic drugs. This includes NSAIDs and repeat exposure to contrast material. The transient renal disease is considered those who meet criteria but return to baseline renal function within 3 months. In severe cases where supportive care does not resolve the injury, hemodialysis is required. These patients will become anuric, have electrolyte imbalances, and multi-system organ failure. Prevention. As mentioned before, this would be the best form of treatment. However, if you can't avoid using contrast media, you would want to start with risk stratification by determining the estimated GFR and creatinine clearance. This incorporates body habitus, gender, age, race, and allows a patient-specific indicator of baseline renal function. You would want to avoid nephrotoxic drugs. This includes NSAIDs, loop diuretics, and metformin. This should all be stopped 24 hours prior to contrast administration and not restarted until at least 48 hours after receiving the contrast media. You'd always want to rehydrate, hydrate before by increasing intravascular volume. You limit the amount of vasoconstriction and hypoperfusion. By choosing the appropriate contrast media, you can also decrease the chances of developing CIN. Low osmolar along with isoosmolar contrast media has been proven to be the safest. You can always consider alternate modalities. This includes ultrasound, MRI, and plain radiography. And the following is a list of references that I use throughout my PowerPoint. Thank you guys for listening, and I hope you learned something.